This is Dr. S. Devaji Rao, Teaching Faculty, National Board of Examinations in General Surgery at Chennai, India. The following slides shows the books authored by me. Today, through this presentation, I am going to discuss about the differential diagnosis of acute upper abdominal pain. Acute abdominal pain is fondly called as acute abdomen. This is defined as severe abdominal pain of sudden onset. Clinically, patients with acute abdominal pain present in a very characteristic manner. They keep shouting with sounds like ah, ouch, and also they come in a stooped manner holding their abdomen with their hand. As the patient explains his abdominal pain, the clinician starts working in his mind the organs of the abdomen and the corresponding pathologies. The eyes see only what the mind knows. That is the reason why the clinician keeps working his mind to get and recollect all the details of the abdominal pathology. For universal understanding, the abdomen is divided into 10 regions. Two midclavicular lines are used to divide them, and also the line joining the lowest part of the costal margin called the subcostal plane and the interiliac plane, that is the line joining the iliac crest, are taken into account in dividing the abdomen into 9 regions. The upper abdomen is divided into two hypochondria, the right and the left, and the intervening epigastrium. The middle part is divided into right and the left lumbar regions and the intervening part called the umbilical region, and the lower part divided into two iliac fossa, right and the left, and the intervening part the hypogastrium. The external genitalia in males is considered as the 10th region of the abdomen. Here you see the intra-abdominal organs and their locations correspondingly correlated with regions of the abdomen. For convenience, the abdomen is further divided into quadrants of the abdomen. There are 4 quadrants, the right and the left upper quadrants and the right and the left lower quadrant. For further convenience, the abdomen is divided into upper and the lower abdomen by an horizontal line passing through the umbilic. Before we go into the differential diagnosis of acute abdomen, we should know the causes of acute abdomen. For clarity, the causes of acute abdomen are divided into intra-abdominal causes, retroperitoneal causes, and the extra-abdominal causes. The intra-abdominal causes are the inflammatory conditions, perforated conditions, obstructive conditions, vascular pathologies, torsion of pedicle structures, and intra-abdominal bleeding conditions. It may be difficult to remember all these conditions, and it is better to use a mnemonic, and I use the mnemonic inpatients only visit Temple Bay. You can use any number of mnemonics and remember these conditions. Now we go to the upper abdominal pathologies. Predominantly, the pathology is involving the hypochondria and the epigastrium. In the right hypochondrium, you have the hepatobiliary inflammations, the acute hepatitis and the acute liver abscess, and the acute cholecystitis and acute cholangitis. In epigastrium, you have the stomach-related pathologies, the acute gastritis or an ulcer, and the acute pancreatitis. In the left hypochondrium, you have the spleen-related pathologies, the splenic infarct or the splenic abscess. The acute nephritis and the acute pancreatitis, they are very close to the upper part of the abdomen, and so they are also considered. As far as the gastrointestinal tract pathologies and the pain localization, you should understand that the gastrointestinal tract is a midline structure embryologically, and the pain is referred to the midline. Diseases of the foregut structures present as pain in the epigastrium. The diseases of the midgut structures present as pain at the umbilical region, and the diseases of the hindgut structures present as pain at the hypogastrium. Having gone through an overview of illnesses involving the upper abdomen, we go to the history eliciting. While eliciting the history, first point you must know is about the nature of pain. Whether it is of a sudden onset with or without pain-free intervals, whether it is dull or burning or constant or agonizing or throbbing in nature. Each has a specificity. The pain has to be localized because the area of pain and the area of the organ which creates this pain are generally identical. Association of vomiting may identify obstruction in some cases. Association of fever generally indicates infection. Association of jaundice generally indicates infection of the biliary tree or biliary obstruction. Shift, migration, and referred pain are very important factors because shifting pain is seen in appendicitis, migration of pain is seen in perforation, and cholecystitis you have referred pain. There are certain aggravating and relieving factors which give a clue to your diagnosis. Referred pain indicates the origin of pain and the presentation of pain. They are different because there is a common shared nerve supply between these two areas. If you look at the certain examples, the stomach and duodenum present as pain in the epigastrium because they have a shared nerve supply with T5 to T8. Ileum causes pain in the umbilical region because of the nerve supply T9 and T10. The colon presents as pain in the hypogastrium because it has a shared nerve supply of T11, T12, L1 and L2. And the undersurface of the diaphragm, which is generally irritated by the gallbladder, perforated duodenal ulcer and the ruptured spleen, cause pain in the right or the left shoulder correspondingly because they have a shared nerve supply between C3 to C5. Ureteric colic presents as a pain from loin to groin corresponding to the genitofemoral nerve L1 and L2. Gallbladder pathology is present as pain in the right scapula because of the shared nerve supply. There are certain aggravating factors for the abdominal pain. The common ones are physical movements like jolting cause a severity in appendicitis pain and the pain of the peritonitis. Intake of fatty food aggravate cholecystatic pain. Intake of spicy food and alcohol increase the pain in acid peptic disease. Lying supine causes increased pain in acute pancreatitis. Drugs like analgesics and NSAIDs create increased pain in acid peptic disease. There are certain factors which relieve intra-abdominal pain. Vomiting relieves pain in peptic ulcer. Intake of bland food relieves pain in peptic ulcer. Local pressure gives good relief in colicky pain. Leaning forward gives relief in pancreatic pain. Drugs like antacids and H2 blockers relieve pain in acid peptic disease. Now we come to the differential diagnosis of right hypochondrial pain on history alone. When the patient presents with pain alone without any other symptom, it usually considered to be an uncomplicated situation of acute cholecystitis or acute gastroduodenitis or acute hepatitis. Vomiting generally is an accompaniment of all these diseases and it is not a very specific symptom to be relied on. Of the three conditions given here which can present with pain, there is a small difference in acute cholecystitis. The pain related to acute cholecystitis radiates to the right shoulder or the back, which is not generally seen in acute gastroduodenitis or acute hepatitis. Vomiting, if it is hematemesis, you must think of an acid peptic disease and gastric malignancy. Now we see an additional symptom of fever. Fever generally indicates infection, which may be mild in acute cholecystitis and acute hepatitis. It may be severe or high grade temperature when the sepsis is local, like empyema of the gallbladder, or due to the perforation of the duodenal ulcer or the gallbladder itself. When you see an additional symptom like jaundice, your diagnosis becomes different. The pathologies are related to the hepatobiliary tree. The acute cholecystitis may present with mild jaundice. Choledocholithiasis presents with obstructive jaundice. The acute hepatitis with mild jaundice. Cholangitis, acute liver abscess, and choledochal cyst are all presenting with jaundice. I mentioned about the colicky pain here also because in the right hypochondrium, the biliary colic is one of the common conditions. The right renal colic is also a possibility. Now we come to the colics. A colic is defined as a sudden squeezing or griping pain lasting for about 3 to 5 minutes with pain-free intervals. The point to be noted here is the pain-free intervals, which is very, very important to define a colic. Colicky pain is a type of a pain caused by the tubular structure which is trying to overcome an obstruction like a calculus. In the right hypochondrium, biliary colic is one of the only possibility and the cause is gallstones. All these colics are associated with nausea, retching, and vomiting. Now comes the clinical examination, which has to be done systematically in a manner of inspection, palpation, percussion, and auscultation. During inspection, the abdominal distension is to be noted, whether it is localized or generalized. Localized distension indicates an inflammation in that localized area, or a generalized distension shows a distension due to generalized infection. Scars, sinuses, and swellings have to be noted. During palpation, the generalized tenderness has to be noted, or whether the tenderness is localized or not. Guarding and rigidity has to be noted because they indicate the peritoneal involvement. A lump has to be felt well and defined. During percussion, hepatomegaly has to be clearly delineated and the obliteration of liver dullness has to be elicited. When analyzing the differential diagnosis of the right hypochondrial pain, by clinical examination, in an uncomplicated situation like acute cholecystitis, acute gastritis, acute hepatitis, the local tenderness may be the only clinical finding available. In a patient presenting with right hypochondrial pain, vomiting, and fever, on clinical examination you may have only local tenderness if it is acute cholecystitis with mild infection or a liver abscess. If the sepsis is severe, if it is local, it might form an empyema, or due to a perforation, it may cause localized peritonitis. If there is a perforation due to an ulcer or gallbladder, the liver dullness will be obliterated and this finding is contributed. In a patient presenting with right hypochondrial pain associated with vomiting and jaundice, there are certain conditions like acute cholecystitis, cholelithiasis, and acute hepatitis become the possibilities. If there is additional fever and rigor, the diagnosis goes towards acute cholangitis or the liver abscess. If in case on clinical examination a gallbladder is palpable or a different lump is palpable, the diagnosis may be choledochal cyst or the gallbladder malignancy or the hepatic primary or the secondary malignancy. It should be remembered that during the differential diagnosis in the right upper quadrant pain on clinical examination, you should remember the right renal colic or the nephritic pain can present in the right upper abdomen. Now we move on to the epigastrium. In the differential diagnosis of epigastric pain on history, when there is only pain, you think of three conditions: the acute hyperacidity, acute pancreatitis, and acute hepatitis. Vomiting is a common accompaniment of pain in these conditions. If there is a history of hematemesis, you must consider the pathologies of the stomach, the acute hyperacidity, acute gastroduodenitis, and also gastric malignancy. If pain becomes associated with fever, you must think of conditions like acute pancreatitis, perforated duodenal ulcer, and liver abscess. When jaundice becomes an additional symptom of pain, vomiting, and fever, you must consider acute hepatitis, a liver abscess, or a metastatic liver. Like mentioned before, during the right hypochondrial pain, even here, the clinical examination for epigastric pain has to be systematic as inspection, palpation, and percussion. Hepatomegaly and obliteration of liver dullnesses are important clinical signs to be elicited. When we come to the differential diagnosis of epigastric pain on clinical examination, in an uncomplicated situation of acute gastritis or hyperacidity, acute pancreatitis or acute hepatitis, local tenderness will be the only clinical sign available. In a patient of epigastric pain who is presenting with vomiting and fever, local tenderness and along with that obliteration of liver dullness may be the important clinical sign indicating the perforated duodenal ulcer. In a patient presenting with epigastric pain, vomiting, jaundice, and fever, the hepatomegaly needs to be assessed properly. If the temperature is low and the hepatomegaly is non-tender, the diagnosis may be metastatic liver, whereas if the temperature is high and the hepatomegaly is tender, the diagnosis may be acute liver abscess. During the differential diagnosis of epigastric pain, please remember to consider the transverse colon inflammation as transverse colitis, which can give rise to epigastric pain, but this is usually associated with diarrhea or dysentery. When we come to the left hypochondrial pain, the causes are acute pancreatitis, that is the tail of the pancreas, acute gastritis, acute colitis, and acute left nephritis. When we come to the relevant investigations, in the hematology, the total leukocyte count is important, and most of the conditions are inflammatory. You find leukocytosis. The ESR may be raised. When you use the radiology, plain X-ray of the abdomen is useful to show the air under the diaphragm and also the radio-opaque stones. The ultrasound of the abdomen will indicate the gallstones, the renal stones, and also assess the hepatopancreaticobiliary anatomy. The CT or the MRI of the abdomen will indicate the gallstones, renal stones, and also assess the HPB anatomy. MRCP is a specific investigation to assess the biliary anatomy. Upper gastrointestinal endoscopy becomes important to rule out gastric mucosal lesions in a patient with vomiting and hematemesis. It will identify the erosions, ulcers, and growths. The treatment plan for the upper abdominal pathologies are non-perforated inflammatory pathologies require only medical management, but conditions like cholecystitis may require surgical management as an emergency. Perforated pathologies and hemorrhagic conditions require emergency surgical management. Thank you very much for a very patient listening.